The following podcast is part of a certified educational activity titled Making Patient-Centric Immunotherapy a Reality in Lung Cancer. Best Practices for Patient Education, Immune-Related Adverse Event Management, and Survivorship Care. Access the entire activity and complete the post-test at peerview.com/XRX860. Downloadable slides and practice aids are also available.
Good morning, everybody, and welcome, and thank you for getting up so early to join us for our session and on this first full day of ONS and to really kick off your learning. So we're really glad that you joined us this morning. So our session today is making patient-centric immunotherapy a reality in lung cancer, and really talk about best practices for patient education, irAE, or immune-related adverse event management, and survivorship care. I'm joined today by my wonderful colleagues that I get to work with again, Dr. Matthew Gubbins, who is a medical oncologist who came in from San Francisco, from the University of California, San Francisco. He specializes and also is the director of the thoracic medical oncology program there. And Beth Sandy, who is a thoracic oncology nurse practitioner at the Abramson Cancer Center in Philadelphia. I'm Marianne Davies, and I am also a thoracic medical oncology nurse practitioner at Yale and teach at the Yale School of Nursing. So our goals for today, what are we going to address? First of all, augment your knowledge on the evolving role of immunotherapies in lung cancer. And this has just been such an exciting time that you'll learn that Dr. Gubbins will be going through. Equip you with the skills to help detect, assess, and manage immune-related adverse events, and then provide some guidance and resources for educating, engaging, and supporting your patients with lung cancer. So we'll start with masterclass number 1. So I'd like to ask Dr. Gubbins to come up and start our first session. Welcome, Dr. Gubbins.
Thanks, Marianne. Always good to see everybody at 6 a.m. I'm from the West Coast, so it's 3 a.m., so I hope you'll forgive my fluency, but I'm that excited about immunotherapy, and also really to be here with you all. You are at the first line. You are seeing our patients and hearing these symptoms sometimes for the first time before we do as oncologists. So it's so important for you to be really well-versed in these and be our partner in terms of really providing the best care for our patients. So my task over the next few minutes is really to just kind of give you a really high-level overview of where we are in terms of using immunotherapies in lung cancer, non-small cell lung cancer specifically. How do we choose from all these many, many options? So let's just start with the case. What I've got here is a 72-year-old man, 30-pack-year history, but quite a long time ago, and he was found on a screening study. So this is a heart study, not a symptom-based study, to have a 3.4 centimeter mass in the right lung. A PET-CT confirmed that the right lung was active. He also had lymph nodes involved and, unfortunately, several bone metastases. MRI was thankfully negative. Pretty healthy guy, ECOG 0, so really no symptoms from the cancer at presentation, and comorbidities were not unusual for a 72-year-old, hypertension, gout, and dyslipidemia. And really just left upper back pain, but not breathing issues, no coughing, none of the like. He has a biopsy on EBUS, that's endobronchial ultrasound through the airway, finds adenocarcinoma. And on testing, he's found to have a KRAS mutation, G12C. About 12% of our patients have this, and a PD-L1 level of 0%. I've been at this for a decent period of time when I had a lot more hair and a little less gut. All we cared about was non-small cell versus small cell. And we didn't have much to offer. You had first and second line, you had hospice. There was really a dismal time for lung cancer. But over the years, first of all, we realized that adenocarcinoma versus squamous cell had differential options, differential kind of behaviors over time. So it was important to know that difference. Of course, though it's not the focus of today's talk, now we have this big pie on the right that tells us that we can figure out what the genetic drivers are of these tumors. And for about half of that pie, we have often pill-based therapies that either in the first line, second line, third line might be highly effective. So really this landscape has changed in our lifetimes. And it's really been exciting to see, but it makes it more confusing a picture. Immunotherapy, though, really has changed the world in all of cancer, but especially lung cancer leading. And I show this almost a lot of the presentations I give. This was the New York Times article the day the first PD-1 inhibitor, happened to be Pembro, happened to be for melanoma, though lung cancer was shortly thereafter, for 10 years ago that this era started. But I love this article because in the third paragraph, they said cancer researchers have been almost giddy. You meet oncologists, we're not usually giddy, but we're giddy about this. It's been exciting. And in these 10 years, we now have stage 4 patients we used to quote less than 1% 5-year survival. It still ain't high enough, and my longevity colleague will attest to that, but we can see a sizable minority of patients who were alive that day who are alive today. So really key differences. But we're also learning, as we'll talk about today, about some of the side effects that emerge from this very powerful class of medications. So just really high level, how did these drugs work? And I'm going to take you back to school and immunotherapy. How does the immune system work, and how can we leverage the immune system to help against cancer? Well, remember those T cells. T cells are the ones that recognize an intruder, if you will, and then once they've identified them, bring the forces to bear to defeat that invader. A bacterium is very different from a human cell, but a cancer cell is kind of a human cell that's morphed, right? So it's a little harder to recognize. But part of the problem is that the PD-1, PD-L1 pathway, which is very important for turning down an immune reaction. You don't want to be inflamed forever. That's a problem. That's autoimmunity. You want to be able to turn things down. But the problem is when the tumor activates this system, when the tumor is showing a PD-1 to the T cell, and the T cell says, okay, I'll lay off. So the tumor is thwarting an immune system reaction. Well, if you block that checkpoint, then the T cell's back on. Then the T cell's activated. Then the T cell can activate the tumor. So basically, the first generation of drugs have an anti-PD-1 and anti-PD-L1 on either side of that interaction to block that calm down message. So the T cell's not deactivated, it's activated and can do what it wants to do. So the first set of exciting approvals were to say that in a subset of patients, we can give immunotherapy alone. You compare immunotherapy to chemo, it beats chemo. And what we saw was in those patients where the tumor expressed high levels of this PD-1. And that makes sense. The tumor was using this trick to turn down the immune system. You block that, the trick is thwarted, the immune therapies work. And so what you see, pembrolizumab, atezolizumab, cemiplimab, all these drugs, highly effective in PD-L1 50% or higher without even having to use chemotherapy. We save it for later. Really fantastic news. But what about patients whose PD-L1 in the tumor is lower, less than 50%, or even 0%, about a third of our patients in metastatic disease? Well, one idea was to say, let's leverage another immunotherapy trick, nivolumab and ipilimumab, so PD-1 and CTLA-4, which is another checkpoint that the immune system uses to turn down, but the tumor can use. So if you use both those, use 2 checkpoints, you block 2 checkpoints, activate the T cell, that can work even at levels PD-L1 low, 0 to 50%, though technically only approved for 1% or higher. But do we have other combination options? Well, we do, and that's probably what we'll talk about today. You all, in the nursing situation, often are talking to patients about watching the fact that when they're on chemo, their immune systems are somewhat suppressed, right? All the talk about the diets and trying to avoid sick folks. Well, why would we want to suppress an immune system and then give immune therapy? Well, there is a method to the madness. On the left here is this kind of cell that this slide that shows that when chemotherapy hits the cancer, I just think of it explodes the tumor. The cancer cell contents are exposed to the bloodstream for the bloodstream to kind of take and process. Well, also released are pro-inflammatory cytokines and other apoptotic pathways and antigens. Antigens are these little things that activate the immune system. So when the tumor's exploded, the antigens are sent out into the bloodstream, and suddenly the T cell has that antigen to react to. So if you kind of think of it, the siren is on, so the T cell soldiers, it's hard to sort of be militaristic, are activated. They are more on guard, and then the whole immune checkpoint mechanism of action works. The antigens are presented, these little partial tumor cells, if you will, and then they're primed to work. The T cells get out to the tumor and kill the tumor. That's how chemo actually makes immunotherapy work better in certain circumstances. And that led to a whole bevy of combinations of chemotherapy, usually platinum doublets, carboplatin with pemetrexed or nab-paclitaxel or paclitaxel, along with pembrolizumab, atezolizumab, cemiplimab, durvalumab, nivolumab, ipilimumab, tremelimumab. This whole kind of word salad, though, but to show that each of these regimens on this slide beat our traditional chemo that we've been using for the last 20 or 30 years. So really exciting. How do we choose from these, though? Because in that slide there in the middle, all those 7 regimens, did I count that right? 7. Sorry, it's early in the morning. All 7 of those regimens are approved for all comers, any PD-L1 level. There are some points about histology, some points about PD-L1 status and preference, but all those are approved. How do we choose? And then when patients do have high PD-L1, how do we choose to use chemoimmunotherapy versus immunotherapy alone? How do we choose? There's 0 head-to-head data. There are a couple of studies that are accruing, but you can imagine there's not that much interest in companies who are making these drugs to test against each other. We don't have head-to-head data. All good data against chemo, just no data against each other. So we're kind of forced to do these kind of side-by-side comparisons of trials and also look at the patient in front of us. How heavy is their disease burden? If I don't get a response with my first cycle, for my first couple cycles, do I have time to go to chemo if I omitted it at the beginning? How severe are the symptoms? Can they take the chemo? Can they take a double immunotherapy versus a single? How's their performance status? What's the histology? Some interesting work at cemiplimab, maybe some differential benefit in squamous. History of autoimmunity. If you come into my clinic with ulcerative colitis, am I very excited about giving you double immunotherapy? I'm not. So all these factors play into, as well as patients' goals and preferences. I work in the Bay Area. We have a lot of patients who really want to avoid chemo like the plague. And if I can offer that in a safe, effective way, I'm happy to. But other patients, I have to say, well, the efficacy isn't there. Let's talk this through and explain why chemo might be a compelling addition. So returning to our case, again, 72-year-old man, stage 4, KRAS G12C mutated. Again, I made that point before. KRAS is an exciting field for another 6 a.m. meeting. There's not a role for KRAS inhibitors in the first line. These are second line and beyond drugs for now. We're working on that. And we don't give a single agent immunotherapy when PD-L1 is 0%. But a lot of the other multiple combinations are reasonable, but you really do want to have some chemo on board and some immunotherapy. Now, we always start using drugs in the metastatic setting where the options are fewer. We cure some patients with stage 1, 2, and 3, but not enough of them. And so the question once we establish immunotherapy in stage 4 is, how can we bring it back to earlier stage disease and meaningfully improve outcomes, including, hopefully, cure rate and survival? So the first pass was to go right from stage 4 to the highest of the stage 3s, those patients who have too much disease to be resected, but who we have tried to cure over the years with chemo plus radiation. Rough regimen, 6 or 7 weeks daily radiation, chemo weekly or heavy dose every 3 weeks. We've been doing that for 20 years, and we cured maybe 25% of people if you look at 5-year survival. Well, again, I won't belabor the data. If you add a year of durvalumab, which is a PD-L1 inhibitor, after that chemo radiation, you're on that blue line. That doesn't raise it to the top the way we'd like it to, but there's a meaningful difference between those two. And so for patients who have a response to chemo radiation that we did with curative intent, we do now offer a full year of durvalumab with the hope of getting people up on that blue line, out longer survival, hopefully more people to cure. So that's a now standard of care. And we're trying to tweak this and improve it as well, but that's the current standard of care. And the more exciting thing more recently are the patients who are able to go to surgery, stage 1, 2, and 3As, where we go to tumor where we say, hey, surgeon, this is a patient where we might be able to get all the disease out with good margins and at least afford a chance of cure. These are patients where if they had stage 2 or 3, even if they went for surgery, we would still give them 4 cycles of chemo in the hopes of just improving that cure rate, getting those, kind of mopping up those last little residual cells. But can we improve the situation with immunotherapy? So basically, there's been a couple approaches. One is to say the first set of trials that led to approval were actually on the bottom here. So instead of giving just the 4 cycles of chemo after, should we give a year of immunotherapy? And in these randomized controlled trials, what we found was that both atezolizumab and pembrolizumab had benefit for that year of therapy after surgery versus not doing it. It turns out that atezo is approved for PD-L 1% or higher, and pembro is for all comers. So that was an important, the benefit was real, a little marginal, but real. And so an important addition to our set of options. But again, this idea of saying, let's do this neoadjuvant therapy. The patient hasn't gone to surgery yet. The tumor is in situ. Maybe that's a better time to use immunotherapy when the immune system has a bulk of tumor to respond to. Again, method to the madness. And that was the study that I questioned you about, nivolumab plus chemo for 3 cycles before surgery. And what did we find? 24% of patients, after 3 cycles of therapy, 9 weeks of therapy, you couldn't see a cancer cell in their specimen. Now, it's not 50, it's not 100%, but 24% compared to 2%, I know which bar I'd rather be on if it's safe, effective treatment, right? Because we have shown that having a pathologic complete response at surgery really improves your outcomes post-surgery. And this is now, that's a quick readout. We know that as soon as surgery happens. This is the data that's maturing over time. Is there eventually going to be an event-free survival and ultimately an overall survival and cure benefit? We don't quite know yet for this trial, but those lines do keep separated. And at 3 years, again, we're seeing that overall survival immature, but very compelling. And so basically, now that we have both adjuvant, meaning after surgery, neoadjuvant options, now there's a set of trials that say, well, why don't we do both? Maybe a belt and suspenders approach, if you will, or maybe more charitably, the idea of saying that if you don't quite eradicate everything at surgery, would additional time on immunotherapy yield more benefit? And we have an approval there too. The Keynote 671 trial led to the approval of pembro and chemo for 4 cycles, then surgery, and then you finish out a year of immunotherapy on the back end. Again, no head-to-head data as yet, and we'll have to see how these curves look. But this idea, again, of integrating immunotherapy to stage 1, 2, and 3 disease especially is very compelling. So in summary, what we have is a whole bunch of approvals, not a lot of head-to-head data, but very compelling data that shows that our old standard of chemo alone is out the door. Metastatic disease, high PD-L1, you really can technically get away with PD-L1 inhibitor alone. And in a well-selected patient, that is the right answer. But you can also offer chemo combinations and PD-1, PD-L1, CTLA4 combinations as well to potentially improve outcomes. In the early stage, when we have resectable disease, we are increasingly saying for fit patients who we can look at as a group to offer either neoadjuvant therapy, chemo plus immunotherapy, for now nivolumab is the approved drug, perioperative, so doing pembrolizumab plus chemo, then going to surgery, and then finishing out a total year of pembro on the back end. Or for patients who go to surgery straight away, but have PD-L1 expression or have stage 2 tumors, to give an adjuvant year of atezolizumab or pembrolizumab to improve outcomes. And then for our patients who go for chemo radiation, offering them that year of durvalumab clearly improves outcomes. That's the state of the art today in 2024. We have a lot of work to do, as our LUNGevity colleague pointed out, but the change is meaningful. And I think now in the presentation, what we're going to move toward is saying, we're using these drugs, how are our patients doing? What are the unique side effects, toxicities that arise when we're working with the immune system? How do we recognize them and deal with them? But with that, I really appreciate your attention this morning.
Well, thank you, Matt. Very exciting times to be in lung cancer. I know I've been in lung cancer now for 20 years, and to see the evolution and all of the options now that we can discuss with our patients is really exciting. And to have the opportunity to say we can talk about survivorship issues, right? That's really just amazing. So as Dr. Goodman said, we're going to move into now really how we recognize and potentially mitigate some of these potential side effects that come along with these. All of our therapies do have side effects. And how do these differ for immune therapies? So we use kind of a several pillar approach in terms of how we can address these with our patients. The first thing we think about is there a way to prevent some of the toxicities associated with them? Are there some assessments, risk assessments that we can do? How do we educate patients? Medication reconciliation is extremely important, and certainly a role that all of you in this room have. And monitoring these patients, and what strategies can we use, including telephone triage strategies, and then what resources do we have that are available for us. So we know that irAEs, or immune-related adverse events, can affect any organ system, which is a little different, as we'll talk about, than standard cytotoxic agents. So if we kind of look at the entire body, you can see every organ system could be affected. And those that are in the red are those that make up the higher percentage of potential occurrences. More than 10% of the population that receives an immune checkpoint inhibitor may develop this. So hypothyroidism, hepatitis, arthralgias and myalgias, rash and pruritus, colitis and diarrhea, uveitis, scleritis, conjunctivitis, so ocular toxicities. And those that are the next tier, that 1% to 10% population, is hyperthyroidism, which typically is something that occurs and precedes hypothyroidism, hypophysitis, pneumonitis, very significant toxicity that we'll talk about today, particularly in our lung cancer population, and then myocarditis, potentially life-threatening toxicity. And the others all occur at less than 1% of occurrence. When we look at the toxicities, we break them down to what are the most common toxicities that patients report, and then what are those that are really of special interest that we know that we can attribute to the immune system or activation of that body's immune system. So the more common side effects that patients will report is diarrhea, fatigue, nausea, pruritus, and rash. And then the ones that are of specific interest to us that are immune-related are increased ALT or transaminitis or hepatitis, so that all falls into that same category, colitis or diarrhea, hyperthyroidism, hypophysitis, hypothyroidism, and pneumonitis. And you can see, based on the bar graph, if you can use your little kind of tool up here to see the various rates at which these occur based on the specific checkpoint inhibitor that's used and whether or not it's given as a single agent or a combination agent. So let's just take our eyes over to the right-hand side. If we take a look at colitis, we can see that, and the kind of the peach color bars here, are those regimens that include a dual checkpoint inhibition. So that includes the ipilimumab and nivolumab. And so you can see that the experience of the toxicity is increased in those patients that receive combination checkpoint inhibition compared to those that receive just a single agent. And there's also a difference in the severity. With most often, these side effects are going to be of low grade, so grades 1 to 2 versus 3 to 5, which are the more severe. And we'll kind of break that down by each of these sites as we go through the morning. So while they're mostly well tolerated in general, usually low grade, we do really have to be attuned to the fact that they can cause life-threatening complications and even deaths in some cases. So it's really important for all of us to be monitoring for those potential risks of those fatal toxicities. If we take a look at, first of all, to the left-hand side, the graph, when we look at the fatalities that can occur due to chemotherapy, they've been attributed to about 1.4% of patients receiving just straight cytotoxic agents. And that's much less for patients that are receiving a checkpoint inhibitor. Less than 1% if it's just a straight PD-1, PD-L1 inhibitor, and upwards of 1.2% if it's a combination agent. So at least overall less than the cytotoxic agents. If patients are going to be experiencing a fatal toxicity, the median duration on this scale on the side is about 40 days if they're receiving a single checkpoint inhibitor. However, the risk significantly increases and that time shortens if a patient is receiving combinations. So if they're receiving both the ipilimumab and the nivolumab, that shortens to 14 days. So keep that in the back of your mind because we're so used to saying that toxicities from immune checkpoint inhibitors usually occur much later in the trajectory of therapy. But if they do have an acute reaction and if it's going to be kind of a fatal outcome, then that is a much shorter window that we have to be in tune to. So what are those things that cause fatalities? Well, colitis, pneumonitis are the key, but particularly if we look at the lower right-hand graph here, you'll see that these are the number of cases reported of each of the incident, and then these are the fatalities. So even though colitis is reported much more frequently, and pneumonitis and even hepatitis in our population, the ones that actually are much higher risk on a percentage rate are actually myocarditis and myositis, and also hematologic toxicities. So those particular toxicities are of very special interest to us when we're monitoring our patients. So keep that in mind, particularly when we go to our cases later in our presentation. So timing, in general, I just talked about the timing for the potential fatal outcomes, but timing of toxicities is usually within within weeks to months after the initiation of the therapy. This is a little bit busy graph on the right-hand side, but this is really the trajectory is over 24 months. So while some irAEs may occur shortly after the initiation, some can occur after several months of a patient being on therapy, and some even after several months of discontinuation. So our monitoring of patients does not stop just because we might put them on hold for their immune checkpoint inhibitor. So the timing is very variable. Usually within the first couple of months, this is where we'll see rash and diarrhea, and a little bit later on is typically with the onset of endocrine dysfunctions, liver dysfunctions, and pneumonitis. So just to kind of recap in terms of the differences, we're really very well educated in the cytotoxic toxicities. Almost all patients are going to experience at least some type of moderate to severe toxicity. It's usually very well described. Usually only a few organ systems are involved, mostly the bone marrow. And the time course is well established. It's typically right shortly after the initiation of that therapy. Immunotherapy is much more variable, however. The majority of patients are not going to experience a toxicity from the therapy. The profile is very variable. As I said, any organ system can be involved, and the time course is variable, as we just pointed out on the slide before. And it is unpredictable. I know there was a question earlier, is there a way that we can predict if a patient is going to have a toxicity? And there's a lot of work being done on this now, because right now we do not have significant predictive biomarkers to say, oh, this patient is definitely somebody we know is going to develop colitis, so we can monitor this over time, or this is somebody we definitely know is going to develop nephritis. We don't have those markers right now, but again, a lot of work is in the field right now looking at that. So I hope I answered that question for you. So what are some things we have to think about when we're looking at the toxicities? So we have our acute toxicities that occur shortly after the start and within the first couple of months. We have some chronic toxicities that may start out a little bit more low grade and then just kind of hover even into survivorship for patients. And then during that time, what are some of the things we need to think about? Do we have to hold the therapy? Can we continue the therapy? At what time do we have to think about, do we have to restart some therapy? Should it be an immune checkpoint inhibitor, or maybe do we have to switch therapy? So there's a lot that goes into really managing that toxicity and how we move forward. So there are some risk factors that are associated with irAEs, and we're learning a lot more about this as well. So I'll just point out a few on the side. One is age. Patients that are over the age of 60, those that have a worse performance status, so ECOG of greater than 2, those with a stronger smoking history, those with either a large BMI, so greater than 23, or those that have significant sarcopenia and loss of muscle mass. So the two ends of the extreme are at higher risk. Those with very high disease burden, those that have a high tumor mutation burden, and that's something that we see on the pathology report. It's not reported out on every single pathology report, but you may see that in some of the notes. Those that have received combination chemotherapy, so if you're having those regimens that Dr. Gubin talked about with chemotherapy and an immune checkpoint inhibitor, you're going to be at higher risk for developing a toxicity. Antibiotic use. So there's a lot of work that has gone into the use of antibiotics, particularly in the weeks leading up to just pre-immune checkpoint inhibitor. And this, I'm just going to put a plug in here for antibiotic stewardship. That's one of the big reasons that we really try to say we want to keep people off of antibiotics if they don't need to be on it, particularly for some random colds, et cetera, because the thought is if you're taking those antibiotics and it sterilizes the microbiome or the gut, that may actually have a role in effectiveness of the immune checkpoint inhibitor, actually lack thereof, decrease effectiveness if you're a heavy antibiotic user, and also may play a role in toxicity. And those patients with vitamin D deficiency, and that really again speaks to our patients typically with the sarcopenia and low muscle mass. So how do we manage the toxicities when we occur? I'm just going to give you this really good tool to use, and we're going to use this throughout. So the first thing that we use is we grade all of our toxicities, and we do this so that we have a common language. So we use the common terminology criteria for adverse events, and you can download this on an app on your phone, and a lot of organizations even have this. It's something that we're so used to doing as part of clinical trials, but it is the language that we should use for all of our documentation when we're talking about how we're managing a toxicity, because it helps to guide us in a step-by-step approach in how we're actually going to manage the toxicity. So grade 1 is mild, grade 2 is more moderate, grade 3 more severe, and grade 4 very severe. Typically, for the most part, grade 1 toxicities we can manage symptomatically in the outpatient setting. At grade 2, we begin to think, do we have to hold the immune checkpoint inhibitor? Do we begin oral steroids to help suppress the immune system a bit? And then when we get to the grade 3 and grade 4, this is where we're thinking that we're now going to manage these people, upgrade our assessments, and bring them into the hospital in many cases, and where they may need IV steroids. And we'll talk about some of the nuances based on the particular toxicity that the patient has. So just keep in mind, if a patient is going to be on steroids, there are certain parameters that we need to monitor, because of course those come with their own set of side effects. If these patients that need to start on steroids are going to be on long-term steroids to suppress the immune system. And typically steroids are tapered over 30 days. In some cases, we need to treat patients for 4 to 6 weeks, and in some cases even months on steroids. So it's really important that we have some preventive strategies here to prevent, let's say, gastritis, opportunistic infections, and also osteoporosis if they're on steroids for a very long period of time. So for gastritis, patients should be on a proton pump inhibitor, an H2 blocker. Patients at higher risk for gastritis are going to be those that are on NSAIDs or receiving anticoagulation. If you're on prednisone for a long period of time, you need to be on PJP prophylaxis. And if you're going to be on even more extended period of time, you need calcium and vitamin D supplements. And patients should have their blood glucose monitored throughout. So there are some definite, I'm not going to go through these. Please take a look at these. SITC, the Society for Immunotherapy and Cancer, is really, because we're studying these irAEs for so long, one irAE is not the same as another. Is this a recurrent irAE? Is it a delayed onset? Is it a chronic irAE? Is it a multi-system irAE? Is it steroid unresponsive, meaning steroids didn't help it? Is it steroid resistant or even steroid dependent for the patient's life? And again, please use that as a reference tool, because you'll begin to see when we look at how we manage these toxicities, these particular definitions will come into more play. This is where there's a lot of research going on right now. So now I'm going to go through a few of the different toxicities in terms of how we manage our approach, and then we'll get into even more depth as we go through our case studies, in which we'll delve even deeper into some of the management strategies. The key for all of our strategies, as I said, is going to be monitoring the level or the grade of the toxicity. In dermatologic arena, we look at the body surface area that is involved. So whether it's less than 10%, which would be mild, more than 30% is going to be grade 3 or more severe. So you look at the body surface area, but you not only look at the body surface area, you look at the impact on the activities of daily living. Is this patient still able to carry out their activities, or is it impacting their daily activities? The first thing we do in our assessment, and this is where all of our assessments is really critical, is we have to rule out other causes. And that's really key point on every single toxicity, because in most cases, it's a diagnosis of exclusion is what we say. So rule out other causes. Does the patient have an ongoing infection? Is this another drug reaction? Do they have a cellulitis? So you want the patient, these are some parameters to report. Have the patient report the rash, report any pruritus that they have, any oral lesions. Keep in mind that any part of the mucous membranes can be involved as well. You want to assess their total body skin, the distribution of the rash. And then what we're going to be doing is providing a lot of the supportive interventions. So typically topical emollients for patients, oral antihistamines for pruritus. Gabapentin can be very helpful in some cases for pruritus. We always, in all of these toxicities, will engage our subspecialists. So they're really important to help us manage some of the subtleties. So dermatology is very helpful. Some of the newer agents that are on the market right now, and I'm just gonna things like Dupixent and other things can be very, very helpful in managing some of the rashes. So there's a lot of research being done in how you manage some of these immune-related toxicities. And then the other thing is that we may have to consider topical steroids for the rash, and if not, parenteral or even enteral steroids. If a patient is refractory, we have secondary or immunosuppressant agents that can be used. For gastrointestinal, the most common is going to be colitis, and we grade that, and that is going to be based on the number of stools, but also associated symptoms, because you want to keep in mind that patients may have opioid-induced constipation. So the idea is to look at the number of stools above their baseline. We first will rule out other causes such as dietary intake, infection, other medications patients are on. From our perspective, you want to encourage patients for diet modifications, hydration, antispasmodics if they're having any abdominal cramping, the standard antidiarrheal medications, so really maximizing those initially. And if patients are refractory, if they're not responding to steroids, then we will move on to infliximab or vedolizumab, which are secondary immunosuppressant agents that can be used. Endocrine dysfunctions, very unique. We don't see these with cytotoxic agents, and they can come in the form of hypothyroidism, so affecting the thyroid gland, the pituitary gland, or the adrenal gland. Most of these can be managed with hormone replacement. So this is the one category of irAE in which we manage the toxicity with hormone replacement and monitoring particular parameters such as the TSH level. However, once they are stabilized, even if it's a very severe toxicity, we can then go on to continue on with the immune checkpoint inhibitor in this subgroup. So the key is we want to obtain all of those hormone levels. So there was a question as to what are some of the labs we obtain prior to therapy, and TSH and T4 is certainly something that we monitor throughout the trajectory of a patient being on so that we can assess for the onset of hyperthyroidism or hypothyroidism as a patient's going on. If a patient does develop these toxicities, again, we want to keep in mind if they have, that they are going to typically be on, if they have hypothyroidism, the levothyroxine for the rest of their life. So that's key. Even if they've been off of the immune checkpoint inhibitor for months and months, they will be on this the rest of their life. If they develop an adrenal issue, in this case, we're going to initiate steroids prior to any other hormone replacement because we want to help minimize the risk of adrenal crisis in those patients. Rheumatologic toxicities, we believe, are underreported. So those arthralgias, arthritis, we think that people minimize it. Oh, I'm just older, I'm aging. That's what these toxicities are from. So we really do believe they're underreported. So make sure you keep in mind if a patient's reporting those symptoms that this may be irAE related. And the key for the arthralgia is that in most cases they're mild and we can continue on with treatment, but some patients do get real significant swelling and it impacts their ADLs. And so in those cases, sometimes we can actually treat these patients with low doses of steroids to keep them under control. So if it's usually prednisone, 10 milligrams a day or less, if it keeps their arthritis under control, those are the cases where we can continue on with the immune checkpoint inhibitor and we don't have to interrupt therapy. Neurologic toxicities. So this is something that there was a question that came up, and hopefully we can go into more detail later on, but this can come in the form typically of weakness, neuropathy, in the worst case scenario, myasthenia gravis, and Guillain-Barré syndrome. These are exceedingly rare for those more severe, but we want to monitor our patients when they're reporting those levels of weakness, et cetera. And we'll get into that assessment of that level of weakness in one of our cases later on, where this may occur in a cluster of other symptoms. So in most cases, rule out other causes. Are there other metabolic causes? Are there other disease-related causes? Progression? Is it due to chemotherapy that's causing that peripheral neuropathy? So providing physical and occupational therapy can be very helpful, and gabapentin for pain, and then steroids, back to our chart from the beginning, is really going to be the management of choice. Pancreatic, very, very rare, but we may see elevations of amylase and lipase. In most of these cases, these patients are asymptomatic and we just monitor them. This is another case where unless it's really the grade 3 or 4, we don't interrupt therapy of these cases. And we want to rule out other causes. Does the patient have pancreatitis, et cetera? But we focus on amylase and lipase, but I just do want to point out that other pancreatic-related toxicities that can occur, although exceedingly rare, are severe hyperglycemia and even diabetes. So monitoring a patient's glucose level is going to be very important for all of us. And these patients, particularly that if they develop type 1 diabetes, are going to be insulin dependent the rest of their life. We have many assessment tools that are available that you can use and you can download to help you grade toxicities. We have a lot of patient education and resource materials, particularly LUNGevity, and those are available in the back and then in the booth as well that you can use to help with educating your patients. Other resources from ONS, SITC, ASCO, NCCN, all available online that you can download to help you manage your patients. And one thing I just want to end this session with, this particular section with, is that we are now addressing survivorship issues, which is really, really exciting. So On a retrospective study that was just reported out about a year ago, 36% of patients that have advanced non-small cell lung cancer were survivors after 1 year of therapy. But of those survivors, 52% of them still experienced at least one irAE. And some had multiple. So we're going to be long-term managers of these irAEs. We have to be aware of that. And some of them, even 27%, require ongoing management after the year. So this doesn't stop because we end therapy. So the survivorship is really important. So now I'm going to pass along, and we're going to get into some case-based studies to go over some of our other irAEs. And I'll pass it along to Beth.
All right, thank you, Marianne, for that thorough introduction. And so we're going to move on and talk about our patients that we see in clinic and that you are going to see in your clinics and your infusion suites, and how we're going to identify these patients having these toxicities and how to manage them. So I'm going to start off with one of my cases. This is a 71-year-old female with locally advanced non-small cell lung cancer who has a history of radiation to the chest. And for our patients that have had radiation to the chest, which a lot of them may have, we're going to see an increased rate of pneumonitis in these patients. So she's now recurrent and metastatic, and she's on pembrolizumab as a single agent because she had a high PD-L1 expression. So she was getting 200 milligrams every 3 weeks. She was not having symptoms in July of 2018, but scans indicated some ground glass opacities, or GGOs. You might hear that or see that on a radiology report. And this is what it looks like. So this was her CT of the chest in May 2018. We're not seeing a whole lot, but if you see then the scan that's on your right-hand side, the CT of the chest in July now shows that area in her right upper lobe of these sort of ground glass opacities and changes that were not there before. So let's talk about this patient who's not symptomatic. So again, when we grade pneumonitis, we say, okay, grade 1 is asymptomatic, so we only see it on that radiographic imaging, which is actually not that typical. I don't know, Marianne and Dr. Gubbins, do you see that often?
So I would say that occasionally you see it when you're doing your restaging, but most often a patient's going to come in because they have symptoms that are prompting me to get another CT scan. So I think that's the more...
Yeah, the majority of our patients are going to be grade 2, where their symptoms come in, and then we say, oh, let's get a CAT scan and find out what's wrong. But every once in a while, we'll see it as grade 1. And then grade 3 or 4 is severe symptoms, life-threatening. Most of the time, we're going to be hospitalizing those patients. So now, I left the dates up here on the scans for my patient. So July, but now you see in September, it is worse. It's now in the right lower lobe, and the patient now has developed a cough. Though oxygen is still good, now she's developed a cough, and the pneumonitis appears to be getting worse. So I looked at the package inserts most recently because I wanted to give you an idea of how all these different drugs that we use in lung cancer and what the rates of pneumonitis are. So if you look across all cancer types, it's typically only around 2 to 3%. So we're thinking, oh, that's really uncommon. But I wanted to show you what the PIs say in the particular lung cancer studies. And you can see that it is definitely higher in patients with lung cancer than it is, say, for your patients with melanoma or other types of cancer where you're using immunotherapy. This is something we are a little bit more sensitive to. And I think the problem for us as well here is if you look under rule out other causes, our patients have lung cancer. Many of them have a history of maybe COPD. They could be having lots of other things. So Dr. Gubbins, if you have a patient come in who's on immune checkpoint inhibitor and they're now complaining of acute onset of shortness of breath, what are you looking for in this patient, or what other things do you have to rule out?
Right, that's such a key question in our patient population, right? Especially when you say acute, that really gets our hackles raised, right? If you have kind of a steady change, that's different. We catch that on restaging, but acute, we are thinking about infection. We are thinking about pulmonary embolism. A double-digit proportion of our patients will have a PE in the course of their treatment, so that's an acute finding. Infection is out there. COVID was notorious in the early epidemic for having multifocal ground glass all over the place. So these are really important to rule out. Some of them are reversible. They have very different approaches and workups and treatments.
Yeah, and the main way to do that is to get a CAT scan. So I wouldn't typically, if somebody's acutely short of breath, if I'm thinking PE or pneumonitis, a chest x-ray is not going to show that. So you have to get a CAT scan, and typically we'll get it as a PE protocol so that we can make sure we're ruling that out. But what did you say? Ankles raised? What was your?
Hackles.
Heckles. I was like, your heckles are raised. I don't know this term. Okay, so my heckles are raised. So I might also be thinking pneumonitis because they're on an immune checkpoint inhibitor.
The thing I got to throw out there, these days so many people have pulse oximeters at home, or it's easy to get them at CVS or, no brands. But it's so important because people, if you know their baseline's in the high 90s and suddenly they're acutely short of breath and they're 92, that may not be ER level, but it's something has meaningfully changed. So that's a nice tool.
I know. I love that our patients have pulse oxes now at home. It's so
and
helpful.
their activity level, that's typically what they'll report to you. It's like, I used to be able to walk the dog. I can't walk the dog anymore. I can't go up the flight of stairs. So their symptoms along with their oxygen saturation is oftentimes what brings them in. Patients are so, attached to that pulse oximeter, which has actually been very helpful.
It is actually really helpful. So in this patient, initially, surprisingly, she wasn't symptomatic, but then she became symptomatic once that September CT scan came around and showed that it was worsening. And I think typically it's going to worsen if we don't do anything about it over time. So she was initially grade 1, but now she's grade 2. So how do we manage this based on the guidelines? So here's the answer to your question. So grade 1, which is what she originally was, you can consider holding immunotherapy and then reassess in a couple weeks and see if the patient has become symptomatic. So for me with that patient, I did hold immunotherapy because I was worried. I'm like, great that you're not symptomatic. I'm not going to start steroids because you're not having any symptoms, but I'm going to check that again next month, that CAT scan, and see if this is worsening. And sure enough, as you saw, when we did recheck that scan, the patient was having symptoms at that point, and we saw it radiographically worsening. Once it got to grade 2 where she had symptoms, then you're definitely going to hold immunotherapy and start your steroids. Now you can see at the bottom if it's severe grade 3-4, this is where you're not only going to hold, you're going to discontinue immunotherapy. And a lot of these patients, you need really high dose steroids, often in IV formulation, and many of these patients need hospitalized as well. And again, there's your grade 3-4, discontinue, and heavy dose treatments of either steroids or even immunosuppressives at that point. So again, initially was grade 1. I guess we can continue treatment, though I would be hesitant. You have to think about that. Pneumonitis is one of those ones that you kind of need your lungs to live. So I'm hesitant about continuing. A rash, yeah, but lungs, you need them. So then the next scan, it was radiographically worse, so we stopped the treatment and started prednisone at 1 milligram per kilogram. And I put weight on there just to give you an idea, because all of us are like, what's 2.2 divided by? We're always trying to, what's the kilograms of the patient? So therefore, this patient is at 150 pounds, is around 60 to 70 milligrams per day. So think about that in your head when you're treating maybe a 250-pound patient. This is going to be a lot higher. Responded well to prednisone, and she was able to restart. We can re-challenge them if they were grade 2 and they go through that prednisone taper and they get back to a normal level. So really my pearls for managing pneumonitis, get the CAT scan, because you got to rule out everything else. Chest x-ray is not going to be enough. Baseline pulse ox is so important before you treat patients. So before you even start the immune checkpoint, know what that baseline pulse ox, do they live at 92 normally? So 92 might be changed. Do they live at 99 normally? And now they're 92. That's a difference. Shortness of breath, dry cough, and hypoxia. These are the most common symptoms that patients are going to complain of. Manages with high-dose prednisone, taper over that 4 weeks, or like Marianne said in hers, 4-week taper or longer, sometimes 6 to 8 weeks if you're worried that they're going to rebound or recur or flare up. Don't do it faster or else they're going to flare, and then it's just going to be the longer time that you're going to need to keep them on steroids. And I like to make sure I repeat that chest CT before I'm going to re-challenge them, because I want to know on that scan that ground glass opacity stuff is better, if not gone, before I re-challenge them. Anything else that Marianne or Dr. Gubbins you want to add on management of pneumonitis? This one is hard sometimes in lung cancer because it could be other things causing it.
No, I would say I think it is really challenging. The other thing is to bring that patient in frequently. I think in the first couple of weeks when you start them on the steroids, you should see typically a rapid improvement within that really short order of their symptoms. You may not see them clear on their scan, but you should see their symptoms improve. So I bring them at minimum once a week in that first couple of weeks before I begin to even think about tapering.
Completely agreed. And again, what point's important too, that CTs are a lagging indicator sometimes of improvement. And I share your concern, Beth. My threshold for restarting therapy is quite high, and it's very contextual with whether options are available and how bad it was. But we can re-challenge, but it's always with caution. And a lot of these patients, I'll kind of let them actually stay off therapy, because sometimes when you have a bad irAE, they actually still have a durable response after stopping therapy for that adverse event. So very, very nuanced discussion.
Very nuanced.
Very team-based.
Agreed. All right, I'm going to turn it over to Marianne for our next case study.
Great, thank you, Beth. That is probably the most challenging. That is probably, I think, we would all agree, one of the most challenging in lung cancer in terms of managing toxicities. So now we're going to switch organs. We're going to go to the liver and talk about hepatitis. So we've got a 62-year-old female. She initially presented to the ED with dyspnea, and she had a good performance score. But the concern with her was unexplained dyspnea was, does she have a pulmonary embolus? And she indeed did on a CTA. So she's got bilateral pulmonary emboli. She was started on enoxaparin. But incidentally with that was found to have a right middle lobe mass with hilar and mediastinal adenopathy and liver metastases. So a biopsy was done. She had PD-L1 expression of 10%, adenocarcinoma, no other actionable mutations. So she was started on treatment with, because of the PD-L1 expression of the 10%, good performance status, was started on carboplatin, paclitaxel, atezolizumab, and bevacizumab. This is based on the Empower 150 study. People will often say, oh, they're going to get Empower 150, and that's what this is. So your patient, you educate them about the different side effects. We've got cytotoxic side effects. We've got bevacizumab, the monoclonal antibody side effects, and the atezolizumab. So she's got really stable baseline labs when she first comes in. This is on day one. Normal liver function tests, normal ANC, and serum creatinine. So she comes in, I'm just going to point to day 14. So think about timing when you look at the onset of a toxicity. At day 14, 2 weeks after the start, you can see where her transaminase is bumped up considerably. So, and you can also see that she's now neutropenic. So what are we thinking this might be from? I'm going to ask my panelists that when we look at that timing, why is the timing important?
Well, what's hard here is that some chemos can also cause liver dysfunction too. And so again, we have to have a high threshold of suspicion thinking about all of the drugs that are on board, but that's where the time course. ANC, I think we all know, that's nadir. We expect that to be low. That's not unusual. That's not even necessarily actionable at day 14. But the AST, ALT, those are relatively high, especially that ALT. So
exactly.
I think of the magnitude of how it increased too. I mean, I don't know what they're getting, a taxane could cause this, but it's usually a slow increase. When somebody went from a, ALT of 24 to 175 in a matter of a week, that gets my heckles up. Heckles? It gets my heckles. Hackles? It gets my hackles up.
Sorry, well, I'm old. So.
I don't know. I think it's an East Coast term too. It's not just San Francisco. I don't know.
I got to Google a hackle.
Based on our algorithm, again, we're going to, first of all, grade the toxicity, which we did. We've given you that information. And that's really meant to guide our action. The first thing we want to do is rule out any other causes, alcohol use, any viruses, etc. Use of other hepatotoxic drugs and supplements. Acetaminophen is a really big one for patients that we need to be monitoring for. We know she's got liver disease. Does she have disease progression? Well, 2 weeks ago, I doubt that's going to impact her liver function test. She's not typically going to have progression at that speed. So let's look at what the team decided to do. So first of all, we have grading. She's got a grade 3 transaminitis when we look at her ALT, and it was grade 2 for AST. Some of the considerations, do we do a hepatitis and viral panel? Yes, that was done. And GI was consulted by this particular team. And there was some consideration of if we couldn't figure this out, should we do an MRI or an MRCP? Now, this is a case that I throw in here because you may see some unique management strategies. The team decided this. So this is the patient comes in for cycle 2. So this is day 21. They still have an elevation. They're going to hold the paclitaxel and administer the filgrastim with the next planned cycle. So that was the decision going forward. So I'm going to pass it along to Dr. Gubens for the next one.
The last two are really common. This one is not common, but it's important. And it just kind of reminds us we always have to have a high index of suspicion for any kind of odd symptom that a patient has. All right, so this is a 74-year-old gentleman, stage 4 non-small cell, started first cycle of chemo and pembro 3 weeks ago, has past medical, as you see there, including melanoma, actually. We're cured of it, hopefully 8 years ago, and then another resection last year, and then another wide light local excision 6 weeks ago. Goes to urgent care with cold symptoms. Okay. 1 week ago, congestion and cough. And then 2 days ago, myalgias, shoulder, back, thighs. The muscles feel overworked. Patients say, like, I worked out. I didn't work out, but I feel like I worked out. And tender despite that sedentary lifestyle. And short of breath, especially climbing stairs, as Marianne said, kind of not at their own personal baseline. And on exam, you see that there's leg swelling and you can elicit back pain with palpation of the muscles. And on cardiac exam, are in a regular rhythm. And again, that 1+ pitting edema. Here's the kind of the flow for cardiac immune-related AEs, which can include not only myocarditis, which we're talking about, but pericarditis and even heart failure. There's no such thing as grade 1 and grade 2. So a little trick there. Grade 3 is where you start seeing arrhythmia, significant echo findings. We don't have an echo yet on this patient, and we don't have cardiac markers yet, so things like troponins. And then grade 4 is where we got more serious arrhythmias, hemodynamic instability, and very high cardiac markers. As always, what are we looking for? Reporting-wise, myalgias, shortness of breath, palpitations, chest pain, ankle edema. Assessment, blood pressure and heart rate are obvious, but EKG and echo are very important to evaluate. And here's where when people are invoking muscle pain, I'm quick to order these lab values. CK, creatine kinase, or CPK, depending on your lab. Troponins, we think of as a heart attack marker. It's a marker of cardiac muscle damage. So that's a really important one here. And then inflammatory biomarkers as listed. There are other causes here. Again, this patient came with cold symptoms. I have a myalgia if I have the flu or COVID, right? So it's not totally unheard of, but again, your hackles need to be raised, right? And then obviously we want to support them depending on their presentation. But the key thing I wanted to say there was that because this arthralgia was invoked, first you might say upper respiratory infection, but then you hear arrhythmia, there's something off on the rhythm, they've got ankle edema they didn't have before. Your wheels have to be churning a little bit to think about, am I missing something? And this is where the cardiovascular system cluster comes in. So myositis on the right, myositis is, again, it is a myalgia, it is the muscle of the heart that's involved, and absence of muscle fatigability in other muscles outside the heart. Myasthenia is different. I'm a thymoma nerd because I'm a thoracic oncologist, but myasthenia is a rare condition, but we do see it also in immune therapy where people have fatigable muscle weakness. So they get more tired very clearly over the course of the day. They come with ptosis, they have bulbar involvement, and in its later stages, respiratory failure. And so the thing is that we're drawing to attention here is there's this rare but real overlap syndrome where you have myocarditis and myositis and myasthenia. It often happens very acutely after the first dose, not one of these kind of year out kind of things. It's very rare, but when it happens, the mortality rate is over 50%. So going back to this case, again, hearing that arrhythmia, seeing that edema, labs are drawn, AST and ALT very high, troponin very, very high, 8.12, where a normal is 0.03. BNP, a marker of heart failure, is high. CK, which is a more general muscle breakdown product, very high. Aldolase, same, high. And EKG, this patient has a new AFib with rapid ventricular response. This is a patient that goes to the hospital, obviously. I don't think I have to sell you on that one. This patient came in with a cold. They're going to the hospital for a major heart muscle damage issue. They go on telemetry. They have serial EKG. They have troponins and echo. A low to normal EF. So kind of not vanishingly odd for our patient population, but of note. They start methylprednisolone, though, because there is a strong suspicion here this is autoimmune. And this patient happened to be in an academic medical center where there was discussion of use of a clinical trial of a kind of a beyond steroid kind of immune modulator called abatacept for specifically immune-related myocarditis. And unfortunately, as they're kind of being worked up and in the hospital under very careful supervision, troponin actually climbs despite this high-dose corticosteroids. This is looking bad. So cardiology is involved. These are cardiologists not just talking to the patient, they're calling their colleagues at other institutions. So what's here is important is that chest CT, as we talked about before, it's important to look at pneumonitis, but it's important here too because pulmonary dysfunction can also cause some of these. Baseline pulse ox is important. All these things are really involved that are important for other autoimmune-related issues are also important for myocarditis. So again, myocarditis rare, less than 1%, but high mortality, usually quick. And again, weakness, muscle pain, dyspnea, palpitations, and really can progress pretty rapidly to life-threatening arrhythmia and shock. Cardiology has to be involved. Troponin is a hallmark here. You can have elevated CPK from diffuse myalgias and have a negative troponin. That's a different condition. That's more of a myositis, more pure presentation. And again, we're looking at hard things like EKG and echo and cardiac MRI in some cases. As we started in our case, steroids, ASAP, strong IV dosing of methylprednisolone. This is not an outpatient prednisone course. And if you're not seeing improvement literally in 24 to 48 hours, that's where we're kind of flailing. That's where we're going to abatacept, mycophenolate, IVIG. Whenever we're getting to those agents, the patient's in trouble. There is no randomized controlled data for any of those things on the bottom 3 bullets, but that's what we use in the hospital to try to get control of these. As a class, these are probably underappreciated, and Marion made the point that in general, probably arthralgias and myalgias are underdiagnosed. I think we chalk them up to other things, but myocarditis is probably more common than we give it credit for. And so this is a kind of a big database of NCI, CTEP patient population collected from a lot of places. We're seeing that, it looks like about 0.6% have this range of cardiac issues that include myocarditis. And about half of those are myocarditis. Many of them had other irAEs involved. We talked about kind of overlap syndromes, and all patients who had concurrent myositis died. So really, really a key thing to try to find early if it's happening. Now, this myasthenia is interesting because of this involvement. Not only is your heart in trouble from a heart muscle point of view, but you're also losing the muscles of your respiratory system. So you actually can go into respiratory paralysis. You need that ventilatory support. You intubate, you go to intubation and often death. So here are kind of some of the symptoms we've already alluded to. I already mentioned high-dose steroids. We often have to go to secondary agents, but just, again, not so much that this is a common thing you're going to run into in your nursing kind of situation with the patient, but that idea that we have a high threshold of suspicion, and even if you send that patient home with their myalgias from their cold or flu, make sure someone's calling them in a couple of days. Make sure they have some anticipatory guidance to call back if it's getting worse. So how did this patient do? They were worked up for myasthenia, again, given that kind of progressive respiratory finding, and the antibodies were negative, but that respiratory status just declined. High-dose steroids, went to mycophenolate, went to IVIG, abatacept, to ATG. This is throwing the book at the patient, and unfortunately, despite all that, patient needed pressor support, had to be transcutaneously paced, went to tocilizumab even, and unfortunately, never came off pressors and died on day 15. Started in a cold, and died. So just, again, this is not something you'll see, but just we always have to have this high threshold of suspicion. We just want to be aware of things like edema, arrhythmia on your exam, myalgias that aren't the classic kind of thing you would expect with just a simple cold. And we just really have to be following these patients very closely, either outpatient or as they develop worsening symptoms inpatient. It just goes to show these immunotherapies are wonderful. They're changing outcomes. They can have lethal outcomes. And we do mention the word death when we consent our patients for these. And this is one of those situations, very sad, where we see very rapid decline. When you're sending a patient for echo, though, that's where the communication with the team is important. Here's what my suspicion is. This patient is on immunotherapy, so that the echocardiographer actually has that frame of reference when they're doing a test. That's true of all of our evaluations, right? That we want our consultant to know why we're asking the question. That's just always part of good clinical medicine.
And I'm going to take that back to even to Beth's pneumonitis case. I had a patient this past week who I just honestly had their restaging scans done 2.5 weeks ago, and we looked at their scans and they had good response to their treatment. Came back, they were symptomatic, and of course insurance didn't want to pay for another CT. I'm like, I really think they've got pneumonitis, and sure enough, they did have pneumonitis. But you have to explain that and say, I really have high suspicion because of these factors. And unfortunately, 2.5, that's how fast it developed. All right, so now our case, I know we're running a little tight. Look, this is a nice short case. I'm going to talk about nephritis. So we've got a 65-year-old gentleman who's starting on carboplatin, pemetrexed, and cemiplimab for first-line treatment for metastatic non-squamous non-small cell lung cancer. At week 10, this is the after third cycle, their routine labs show that their serum creatinine is 2 and their baseline was 0.8. So just keep in mind, this is now after 3 cycles of combination treatment. So the answer for this, again, the patient got a cytotoxic agent. We know carboplatin and PEM also can all cause nephritis or an elevation in your serum creatinine. They're all metabolized by the kidney. And cemiplimab certainly can cause an irAE. So the answer is to really hold both of those and to allow some other opportunity to assess either the improvement in that toxicity. So all of the guidelines are going to recommend holding both of those to determine the cause. And really it becomes kind of almost self-evident. If the serum creatinine elevation clears before the next cycle, then likely the causative agent is that chemotherapy, the carboplatin, the pemetrexed. And you manage it either with holding the cytotoxic agent and dose reducing. But if the serum creatinine persists or even worsens, then that raises your hackles to think this possibly could be due to the immune checkpoint inhibitor. Now, again, sometimes can get a little complicated because it may be due to both. You may be having a component of both, so that becomes a little bit of a challenge. So again, you want to rule out any other causes. Is the patient on any other nephrotoxic agents? Are they on NSAIDs? Did they just have a CAT scan? So is their CAT scan dye on board, which can elevate your serum creatinine as well? And so monitoring the patient. Are they dehydrated? Are there pre-renal causes, such as the dehydration that could have been causing that? Did they have a lot of nausea and vomiting, let's say, with their chemotherapy agent? And so if you're dehydrated, that's going to, again, bump that up. So you need to collect more information on this. But the tincture of time usually is going to help guide your management for these patients. All right, now we've got another unique toxicity.
All right, this is our last case study. By the way, I looked up hackles. It's the hairs on the back of an animal, or it's the saddle feather of a domestic rooster. Just saying. All right, so let's talk about a fairly I wanted you to know. Let's talk about a fairly rare but an immune checkpoint inhibitor side effect that came up in my clinic. So this is uveitis. That's the eyes, just so you know. All right, so this is a 75-year-old male with a history of metastatic non-small cell lung cancer, adenocarcinoma, no actionable biomarkers. His PD-L1 is 0%. He was treated with 4 cycles of pemetrexed, carboplatin, and pembrolizumab with a good response. And then 6 cycles into his maintenance pemetrexed and pembrolizumab, he presents to clinic looking like this. The 7th cycle. He presents with bilateral eyes being red, no drainage, but very sensitive to light and actually painful with distorted vision. Yeah, I wanted to just tell you, what is the uvea? I mean, I'm guessing a lot of you aren't that familiar with the anatomy of the eye. So the uvea is sort of a term that covers a lot of different structures of the eye. So it's the choroid, it's the ciliary body that contains, the cornea and the iris. The iris, of course, is the colored part of the eye. So the uvea kind of is that entire middle layer of the eye. So when we talk about uveitis, this sort of encompasses also iritis and conjunctivitis as well. So what other causes are you going to rule out in these patients? Of course, infection or some other eye irritant, glaucoma, macular degeneration. Spoiler alert, I can't rule those things out. So what are we going to do first? I'm going to send them to ophthalmology. Yes. And luckily at my institution, we do have a walk-in clinic for urgent eye issues. And this is generally urgent. Yeah, I don't know. Dr. Goodman's used to sticking
My state school does not have that, and we wish we did. So it's really, you have to call your consultant and say, this isn't something to sit on. We need to get
Right. We want this patient to be seen urgently by an ophthalmologist because this is not something typically that I want to mess with. Especially if this could be glaucoma related. You can really do some serious damage if you start putting steroid-based eye drops into these patients. So here are the recommendations for vision changes, and that's going to be the top there. This guy's grade 1 or 2. he's having symptoms, you're going to hold that immunotherapy and then consider topical therapy first. And most of the times, topical steroid therapy is going to work and help these patients. You get pretty good absorption there from topicals. You really wouldn't need to go on to systemic therapy unless this is something severe where their vision, 2200 sounds pretty darn bad to me. So most of these patients are going to be that grade 1 or 2, and topical therapy is going to be helpful for them. So this patient was seen and evaluated urgently by ophthalmology, was started on Predforte eye drops every 6 hours with almost immediate relief. But luckily that ophthalmologist could say to me, I examined this patient, this is not a severe glaucoma issue or a macular degeneration issue. This looks like just inflammation of the uvea. So this patient was able to taper down on the eye drops, and 1 week later was doing very well, had a full recovery, and we were able to resume treatment with pembrolizumab without recurrence of the uveitis in this patient. Okay, so again, our key treatment management, key takeaways. Us nurses are very integral to the monitoring, really, and diagnosing of irAEs. You guys are the front lines. Us nurses, Marianne and I as well, are in the front lines of seeing these patients and reporting that toxicity to the clinicians to make sure this is getting managed appropriately. So don't blow them off. Even minor toxicities, a lot of times, we should be thinking, could this be one of those toxicities? Because if we continue that immunotherapy in those patients, that could even end up being fatal at times. So we have to be really on top of that. We are going to treat with steroids for those grade 2 and certainly grade 3 and 4 toxicities. Most of these toxicities are going to be grade 2. Most patients are going to be symptomatic of them. And a lot of the times this is going to be systemic, except for some of those dermatologic and the uveitis like you saw, we can manage some of those with topical steroids. And the endocrine, with the hormone replacement with the endocrine for the most part. Don't discontinue those steroids too soon because then patients may relapse. So we really recommend if they are needing systemic steroids for things like colitis and pneumonitis, don't do it too quickly. This is not a pulse or a Medrol dose pack. This is a long 4 to 6 week steroid taper so that those patients don't relapse with whatever itis they're having. And then certainly tapering the steroids needs to be supervised. Just like Marianne was saying, I'm going to bring those patients back frequently. This is not like send them home and I'll see you in 4 weeks. Once they're down to 40, 30, 20 milligrams of prednisone, bring them back in so that you can tell if their symptoms are worsening again. And reinitiation of the immune checkpoint inhibitor can be possible. So we can re-challenge these patients if they are either off their steroids or at less than 10 milligrams of prednisone and really have made a full recovery from whichever toxicities they have. The decision to restart is not always clear. I don't know, Marianne or Dr. Goodman, do you want to comment on any cases where you've been hesitant to restart, you weren't sure?
Well, I think that Dr. Goodman's brought it up earlier too. It's not always really an easy choice, but if a patient, let's say, has been on an immune checkpoint inhibitor for several months and they've had an excellent response, I might say, no, we're not going to re-challenge you. That might be maybe they've had enough. Maybe their body's immune system has actually been activated enough and it might be fine just to take them off of therapy and not risk having either a worsening of that itis or developing another itis that potentially could be lifelong.
It just goes to show that we're 10 years into this, we still don't really know how some of these work as well as we wish we did. One of my favorite examples is a patient who had a CNS side effect after 1 dose, landed in the ICU, cerebellar involvement, got over it, never got another dose of that immunotherapy, had controlled disease for years. Other patients get 2 years of disease, go off on schedule, and the disease recurs on the very next scan. So yeah, there's so much heterogeneity in how our immune systems interact with our tumors, interact with our immunotherapy drugs, that it's hard to answer the question. But I think more and more, we also have to grapple with a change in our patients. They're not all going to be metastatic patients with other prospects. These are some early stage patients. And those patients, if they have a bad autoimmune related adverse events, half a year into adjuvant therapy, I'm not touching them again because maybe they're cured from the surgery, maybe they're cured from the chemo, maybe they're cured from the immunotherapy that gave them the irAE. I'm stepping away, keeping in my back pocket for a future recurrence maybe, but big nuanced discussion.
Yeah, I think it is a risk benefit depending on their stage and what their response has been so far. I completely agree. All right, I think we're really at time. It's after 7:30. There was great questions online. We responded to many of them through the online. There was one question I thought was good that I just wanted to end with. I think it was answered online, but I just want to be very clear about when we see hepatitis, it's often going to be the AST and ALT specifically. Somebody mentioned, what if the ALK phos is elevated, but not the AST and ALT? Marianne?
We're typically not using that as an indicator of hepatitis. You can often see if the disease is active, or even if patients are on high-dose chemotherapy, you can see the elevation of that ALK phos. So we use the bilirubin and the ALT and AST as our indications of actual inflammation of the liver. The ALK phos is not a measurement of the inflammation of the liver.
Any other burning questions out in the audience that you have that we didn't answer, or online? Just to give
We're happy to stay and answer.
Yeah, we'll be up here as well. Since
one big question that a lot of people asked is about treating patients with pre-existing autoimmune diseases, and this is a great area of ongoing research right now, and it goes back to our risk-benefit analysis. So for patients that have an autoimmune disease, are they likely to die from that autoimmune disease or die from their cancer? And if you can treat their cancer and keep their autoimmune disease under control, or let's say it's been latent for a period of time, then oftentimes we may select to go down the path of using the immune checkpoint inhibitor. Again, monitoring and engaging those subspecialists as well. So
a very stark decision. People have transplants in our centers. If you had a liver transplant a month ago, you are not getting immunotherapy because I will kill you. But another situation is a patient who's had a renal transplant for renal failure. Well, we might kill their transplanted kidney, but they can go on dialysis. So if the clear and present danger of their metastatic cancer that's high PD-L1 is high enough, we have sometimes made that tough decision with the patient, of course, in very much shared medical decision making. But even those stark decisions depend on the context.
Thank you so much for joining us.
Enjoy your context.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XRX860. This activity is supported by independent medical education grants from AstraZeneca, Bristol Myers Squibb, and Regeneron Pharmaceuticals, Incorporated.